In the 1980s, we saw something that really, I think the first thing that really changed the way that we could deliver medicines for patients, and that was the multi-dose dry powder device.
The first European Respiratory Congress took place in Brussels in 1991, and it was a big step forward because it was the merger of two societies, a clinical one and a respiratory physiology one.
Well, COPD is a huge burden, so it's worthwhile to try to increase public awareness and advocacy for this disease, and this was achieved through the World COPD Day, which was first introduced in 2002. So in 2006, GSK introduced the asthma control test, which really facilitated the assessment of asthma control in our patients, and this made the management of asthma very much easier.
Recently, the biologics have really transformed the management of patients with severe asthma, but we recognize that these really focus on those individuals with what's called type 2 inflammation, severe eosinophilic asthma. And there's still a big unmet need in patients who don't fulfill that criteria.
So I think we can see that a lot has happened over the last 50 years. From small beginnings right the way through to the newer developments. I think it's a very exciting time. We can and we will do much better now and in the future than we have done in the past. And I'm looking forward to the next few years to see how everything progresses.
Good evening and welcome to the webinar on asthma. So this webinar is organized by the Sri Lanka College of Pulmonologists in collaboration with the Kandy Society of Medicine. So we have an excellent lineup of talks for you today. And before we start, a couple of housekeeping rules. So during the webinar, you can send us your questions anytime during the webinar, and you can use the chat box to do that. But however, we will wait until all 4 speakers have given their talks to take up the questions. And we'll try to get our speakers to answer as many questions as possible, but we will have to within the time constraints. So without much ado, so we will start the webinar, and I'd like to invite Dr. Geethal Pereira to introduce the first speaker. Over to you, Geethal.
Yeah. Our first speaker today is Professor Ian D Pawad. He's professor of respiratory medicine at the University of Oxford and honorary consultant physician at Oxford University Hospitals. He's a member of the congregation of the University of Oxford and a professorial fellow at St. Edmund Hall. He was a consultant physician from 1995. He has research interests in the clinical aspects of inflammatory airways disease and has pioneered the use of non-invasive measures of airway inflammation in the assessment of these conditions. He has identified a number of clinically important phenotypes of inflammatory airways disease, has discovered clinically important biomarkers, and has played a lead role in the clinical development of 3 of the most promising new treatments for severe airways disease. Professor Pawad was a co-editor of Thorax from 2010 to 2015, Chief Medical Officer of Asthma UK from 2008 to 14, Associate Editor of American Journal of Respiratory and Critical Care Medicine, and has been Associate Editor of the European Respiratory Journal since 2016. He's the author of over 450 publications and has an H-index of 109, making him the second highest cited researcher in asthma worldwide. He received the 2016 European Respiratory Society Gold Medal for his research and gave the Cunard lecture in the 2004 ERS meeting. We invite Professor Pawad to give his talk on the importance of asthma phenotypes and endotypes in patient evaluation and management. Over to you, Prof.
Thank you very much for those words of introduction, and thank you to the Thoracic Society of Sri Lanka for inviting me to give this talk today. It was interesting to see the video that started off this session and all the developments in asthma and COPD care over the last 50 years, and several key events were highlighted. And I think we're probably in a key period now where a lot of things are happening very quickly. And we're thinking about airways disease in rather different ways. So I hope I can give you a sense of that over the next 30 minutes. A time of great change, a time of great excitement, and a time of new opportunities for our patients. So I'm going to talk about asthma phenotypes and endotypes in patient evaluation and management. I have some relevant conflicts of interest set out here. So we still tend to categorize obstructive airways disease along traditional lines into asthma and COPD, largely using demographic characteristics and the pattern of abnormality of lung function. This stratification is important for patients because we approach these two groups of patients in different ways. For example, we use corticosteroids early and in a fairly blanket fashion in asthma, whereas they're used late and in a targeted fashion in COPD. And comorbidity tends to be much more focused on in COPD, and in general, we have a less optimistic prognosis. So when the labels are made, we start thinking about the condition in rather different ways. And I'm going to ask some questions about whether that really is the way we need to continue to think about airways disease, or whether there might be better ways. So I love this quote from Richard Asher, who was a great medical writer. It's at least 60 years old. And it refers to the taxonomy of disease. And I think the words are particularly relevant to the way we think about and classify airways disease. So we tend to cast these diseases into vast diagnostic receptacles or etiological dustbins. And once we've done that, all thinking seems to stop. And what we've been doing in the last 10 years or so is lifting the lid of these dustbins and poking around amongst the rubbish and trying to pull out of these diagnostic dustbins groups of patients that look rather interesting and who may have common mechanisms driving their clinical problems. So I think that this, as I suggested at the beginning, that really this new thinking is ready for prime time for a number of reasons. Firstly, we've got new methods that allow us to measure airway inflammation, and these look very applicable and simple to do even in non-specialist settings. And in doing that, we've identified clinically important endotypes, particularly type 2 high airways disease, which is a crucially important endotype to identify in the clinic. And we have new treatment options for that pattern of disease in particular. And the reason is because we developed a new way of measuring airways disease. And this is pioneering work that was done in the late 1980s, early 1990s by Freddie Hargreave, who's pictured here with his research team. He developed a non-invasive method for measuring airway inflammation using induced sputum, which proved to be a very successful way of identifying the two major inflammatory patterns that we see in airways disease: eosinophilic airway inflammation and neutrophilic airway inflammation. When we started making these measurements in the clinic, what we found was very surprising. For example, on the left, you can see the induced sputum eosinophil count in patients with asthma and COPD and in normal controls. And you will see immediately that eosinophilic airway inflammation is by no means specific to asthma, nor is it always seen in asthma. So roughly a third to 40% of patients with symptomatic asthma do not have this feature. And maybe 40% of patients who clearly have COPD do have this feature. So when we make the asthma COPD call, we are not identifying a discrete pattern of airway inflammation, which I think a lot of people still assume we are. The other point to make on the right, top right and bottom right, is that the identification of eosinophilic airway inflammation using sputum does allow us to make an important prediction. And that is that the patient is likely to respond well to corticosteroid treatment, be it inhaled steroids in asthma or oral steroids in patients with COPD. You can see the message is very similar. If you have a high blood eosinophil count, you are going to have a good response to corticosteroids. So this process seems to tell us something that's actually quite important, so that there is a treatment option for this patient because they have this pattern of disease. The other thing that we noticed when we started measuring airway inflammation is that there was absolutely no relationship between what we traditionally measure and use to quantify disease severity and the presence of eosinophilic airway inflammation. So you can see here 2 diary cards from 2 patients with severe asthma. The patient on the left, I think you will agree, has got very bad airway function with marked peak flow variability, very high beta-2 agonist use, and very high symptom scores. But in fact, their sputum is entirely normal, so there's no eosinophilic airway inflammation. Whereas the patient on the right has got a very respectable peak flow diary, normal readings, minimal variability, no reported symptoms at all, very little salbutamol use, but their sputum is full of eosinophils, so they've got very severe eosinophilic airway inflammation. So it appeared that symptoms and airway dysfunction on one hand and airway inflammation on the other were rather independent features of asthma, at least. What we did begin to notice is that when eosinophilic airway inflammation was present, the patients seemed to be at risk of asthma attacks, and particularly severe asthma attacks. So the variable that seems to link most closely to eosinophilic airway inflammation was the occurrence of asthma attacks. So one question that arose when we started seeing this pattern is what should be guiding steroid treatment? Traditionally, we use symptoms and lung function measurements to identify patients who need steroids and to titrate the dose. That would mean that the patient on the left was the one that would get more steroid treatment. But in fact, they've got no steroid responsive pathology. Would it not be better to give additional steroids to the patient on the right? And if we did that, might we prevent them having asthma attacks? And that became a very important clinical question. And what we found was that there was very clear evidence, not only in asthma, but also COPD, that if you use sputum eosinophil counts to decide who should have steroids and to identify the optimum dose of corticosteroids, patients do a lot better. You can see the red lines here are sputum-guided management, and the big benefit of treating against markers of eosinophilic airway inflammation rather than symptoms is that patients have fewer severe exacerbations. So it looked to us like we had to get a new model for airways disease, and that our patients with obstructive airways disease have clinical problems as a result of 2 relatively independent processes, or if you like, treatable traits. So on one hand, we have eosinophilic type 2 airway inflammation, which seems to be driving exacerbations particularly. And on the other hand, we have an abnormality of airway function, and I don't think it matters if it's fixed or variable airflow obstruction, that seems to drive many of the symptoms that patients report day to day. This model predicts a number of things. Well, firstly, it predicts that you're not going to be able to optimally manage obstructive airways disease unless you measure both of these traits. and it is not valid to make inferences about the presence or severity of one trait based on measuring the other trait. The second prediction it makes is if you had a treatment that selectively took out eosinophilic airway inflammation, for example, a monoclonal antibody that blocks IL-5 like mepolizumab, the benefits are going to be largely in people who have that trait. It's not rocket science. If you select people on the basis of having airway dysfunction, you might not see a clear signal. But if you select people on the basis of having eosinophilic airway inflammation, you will. And that the main benefit of taking out eosinophilic airway inflammation will be a reduced risk of exacerbations. And one lovely thing is that we did have mepolizumab, and this allowed us to investigate whether this model is in fact correct. So, and I'll show you that data later, sorry. One approach to phenotyping patients with asthma is to perform a statistical approach called cluster analysis. And this is a study that Pranab Halder did in Leicester more than 10 years ago, where he looked at two populations of patients, with mild asthma recruited from primary care and patients with more severe asthma recruited from secondary care, and shown in this diagram in blue. And what he showed was that the severe asthma population in particular are characterized by a marked discrepancy between the two treatable traits we've just discussed. So we have a group of patients who have inflammation predominant disease, whose main clinical problem is asthma attacks, and another group of patients who have what we call symptom predominant disease, whose main clinical problem is that they have high symptoms and often disordered function. And so one of the reasons why these patients might be doing poorly with traditional management is because what we're using to guide anti-inflammatory treatment is in fact not related to the process that anti-inflammatory treatment deals with. So if we're using symptoms to guide therapy, the symptom predominant group would get much more steroids, and the inflammation predominant group would get less steroids. And the reason that inflammation guided management does better is it better identifies these two discordant groups of patients. So it's been quite hard work to get this new way of thinking about airways disease out into prime time, but I do believe it's happening now. And I think some of the reasons have been that traditional disease labels become very deeply embedded, and they become more deeply embedded every time we issue a set of guidelines that reinforces these concepts. I think people haven't accepted that we have the right instruments to assess eosinophilic airway inflammation. Induced sputum eosinophil counts are difficult to do outside a specialist clinic. So I think that's a reasonable concern. And thirdly, I think with airways disease, things are more likely to happen if industry want them to happen. And that's for very understandable reasons. There is a huge market in obstructive airways disease, something like $40 billion a year. And clearly, any change mustn't put that market under too much threat. So I think all of these blocks are slowly being removed. So I was very fortunate to chair the Lancet Commission on Asthma, which published its report 2 years ago, 3 years ago now. And really the major point was that we needed to start thinking about airways diseases in different ways, making the points that I've already made to you. And with Alvar Augusti and a number of colleagues, we published a paper in 2016 suggesting that the focus should move from these rather arbitrary 19th century labels to a new classification system where we focus on what we call treatable traits, which are mechanistic pathways, endotypes or phenotypes, if you like, that drive symptoms or a clinical problem that can be modified with treatment with the result that the patient benefits. And I think there are two dominant treatable traits. We've already discussed the risk of exacerbations as a result of eosinophilic airway inflammation and the presence of symptoms as a result of airflow limitation, be it fixed or variable. And if we measure these two treatable traits, we are in a position to start offering precision medicine, so treatable trait-based medicine rather than arbitrary label-based medicine. So we would offer a different cocktail for the group of patients who have symptom-predominant disease compared to those that have inflammation-predominant disease. And I think if one of the less recognized but crucially important benefits of this new way of thinking about airways disease is it will shine a very sharp focus on those patients that have neither of these treatable traits. And I see a lot of patients in my clinic who have symptoms but no obvious airflow limitation or type 2 airway inflammation. Many of them present with a cough. And cough reflex hypersensitivity is, I believe, a very important treatable trait for which we need new treatments. I also see many patients that have asthma attacks and symptoms, but have no obvious evidence of eosinophilic airway inflammation. And in many of these cases, I believe the problem is infection-driven neutrophilic airway inflammation. And again, we need better treatments for this common treatable trait. Many of these patients get treated currently as if they have asthma and end up on high intensity asthma therapy, which clearly makes absolutely no difference to their problems, nor would it be expected to help them if they have neither airflow limitation or eosinophilic airway inflammation. So measuring type 2 airway inflammation has become possible in the clinic, and it could be done in non-specialist care, including primary care, because we have two really very useful biomarkers. Exhaled nitric oxide, or FeNO, which is increased in the exhaled air in patients with type 2 high asthma as a result of IL-13 induced nitric oxide synthase, which leads to an increase in exhaled nitric oxide. And if you block IL-13 with a monoclonal antibody, such as dupilumab, we know FeNO levels fall to very low level. So this is a great biomarker of IL-13 activity in the airway. The other biomarker we have is the blood eosinophil count, which is increased in a patient with type 2 airways disease as a result of IL-5 production in the airway and systemically. IL-5 induces eosinophil maturation and recruitment and activation. And when we block IL-5 with a monoclonal antibody, mepolizumab, for example, we know that the blood eosinophils fall to very low levels. So these two biomarkers identify different aspects of type 2 airway inflammation, and you might expect them to have additive predictive value. And that's exactly what we found. And if you're serious about identifying type 2 airway inflammation, and I believe you should be, it's probably the most important thing you can do for your patient with type 2 with airways disease, then you're going to want to equip yourself with both FeNO and blood eosinophils. It's now clear that both of these biomarkers are independently associated with the risk of asthma or COPD attacks. And this is across the board from mild, moderate, severe asthma and COPD. You can see on the left in mild asthma, as we move from low to high blood eosinophil counts, the risk of having an asthma attack increases about 3 or 4-fold in patients who are not receiving an inhaled steroid, and that this excess risk associated with eosinophils is not seen in people who are receiving a corticosteroid. And it's the same story in COPD. As the blood eosinophil count increases, the risk of having a COPD exacerbation increases. And this relationship is not seen in people that are taking a regular inhaled steroid. And in moderate to severe asthma, biologics work particularly well in patients with high blood eosinophil counts and high FeNO. and less well in patients with low eosinophil counts and pheno. But the other point to make is that the risk of exacerbations is much higher in patients who have high biomarkers compared to low biomarkers. So in many ways, these biomarkers are like the airway cholesterol and blood pressure. They tell us about risk. And crucially, it is risk that we can treat, whether it's inhaled steroids or biologics. Now, I'm going to finish by very quickly going through some of the treatable traits that we need to look for in the clinic. And firstly, airflow limitation. And I'm going to focus particularly on the patient with more severe asthma and look at options that may be available for us to treat these traits. And clearly in patients with airflow limitation, they're likely to already be taking a LABA-ICS combination treatment, and probably the best option as an add-on therapy is to have a long-acting antimuscarinic agent. These papers from 10 years ago showed that there was a significant improvement in lung function, some minor reductions in exacerbations, but really nothing to write home about. The big signal with LAMAs is improved lung function and symptoms, which is what we want to do with these patients. We've recently looked at the once daily long-acting antimuscarinic agent, umeclidinium, and we've compared the impact of adding umeclidinium to low-dose Relvar to increasing to a higher dose inhaled steroid by doubling the dose of inhaled steroid and giving them high dose Relvar, sorry. And I show here the data by blood eosinophil counts and pheno, and what you'll see immediately is the major impact of doubling the dose of inhaled steroid is to reduce the risk of exacerbations. And it does so in a blood eosinophil and pheno dependent fashion, as you would expect. Whereas the addition of umeclidinium, the major impact is to improve lung function. There's relatively little effect on exacerbations, and the benefits are entirely independent of type 2 biomarkers, as you would expect. So let's talk about eosinophilic airway inflammation, or type 2 high inflammation. We know a lot about the pathways that lead to this process, and there are a number of points where this can be inhibited with monoclonal antibodies, and I've shown them in red on this diagram. The blue squares are other points where type 2 airway inflammation might be interrupted, but where treatment has not been that effective. I think there has been efficacy, but the drugs are not that effective. And in green, you can see some targets that are currently in phase 3 clinical trials that look promising as a means of reducing type 2 airway inflammation. And there are monoclonal antibodies that target IL-5 itself, mepolizumab and reslizumab, that target the receptor, benralizumab, and that target the IL-4 receptor alpha, dupilumab, thereby inhibiting binding of both IL-4 and IL-13 to their respective receptors, because the IL-4 receptor alpha is a component of both. Now, initial experience with mepolizumab was disappointing. You can see on the left that there was no evidence that treatment improved morning peak expiratory flow in patients with asthma who were selected on the basis of having variable airflow obstruction. But if you remember the model that we came up with a few slides back, that is exactly what you would expect. And when you did a study in patients with eosinophilic airways disease based on having a high sputum eosinophil count, and we looked at exacerbations, an outcome that is linked to eosinophilic airway inflammation, there was clear evidence of efficacy. This has been confirmed in subsequent phase 3 studies, and the drug has been available and is being used widely for the last 5 years. The predictors of response to mepolizumab are the blood eosinophil count, which again is what you would expect. It's a marker of IL-5 activity. Notice that the bronchodilator response is negatively associated with treatment efficacy. So what you want is patients that have eosinophilic airway inflammation, but don't have much airway dysfunction. So they have very pure inflammation predominant disease and are likely to respond very well to mepolizumab. The three different IL-5s have very similar effects. I think they reduce exacerbations by about a half, and they do that across the board, and severe hospitalized exacerbations are reduced by a similar amount. They have less effect on lung function, so about 100 mil improvement in lung function, and they appear to be very safe, with only injection site reactions reported more commonly than is reported with placebo. The blood eosinophil count is a very useful biomarker of response to both of these biologics, and efficacy becomes apparent above a blood eosinophil count of around 100 or 150. And it's really very large when the blood eosinophil count is above 500. So anti-IL-5 really is a very effective treatment in this group of patients. Dupilumab, which is coming online in most countries now, is also very effective at reducing exacerbations, and it does so particularly in patients who have high FeNO and high blood eosinophil counts. You can see 60 or 70% reductions in exacerbations in this group. Notice always that also that if you don't treat this group, they have a high risk of exacerbations, whereas the group with low biomarkers have a low risk of exacerbations and no clinical benefit. And it's the same story for lung function. Dupilumab seems to do more for lung function than the anti-IL-5s, which is interesting. All of these three biologics are very effective oral steroid sparing agents, doubling or trebling the likelihood that you can reduce or stop the oral corticosteroids in the patient that requires steroid treatment. You'll see again, dupilumab seems to do a little bit more for lung function than the other two in this population as well. And this is just a summary of what the new biologics can do in a patient with type 2 high asthma. On the left, you can see the clinical effects, and on the right, you can see the effects on biomarkers. And I think as a general rule of thumb, the more completely you inhibit type 2 airway inflammation, the bigger the clinical benefit. So anti-IL-4/13 and anti-TSLP seem to do just that little bit more for lung function and symptoms. And the second point is the effects on biomarkers are exactly what you would expect given the target. So anti-IL-5 reduces blood eosinophils but doesn't affect FeNO, whereas anti-IL-4/13 reduces FeNO but actually increases blood eosinophil count because they're prevented from leaving the vascular compartment. And the third point to make is the biomarker that is most reduced by the treatment is usually the best predictive biomarker. So it's the best, it allows you to predict who's going to respond well to treatment. So FeNO is a very good predictive biomarker for dupilumab, and the blood eosinophil is a very good predictive biomarker for anti-IL-5. Let's consider infection-related neutrophilic airway inflammation. I think that this is the population that respond well to macrolides. Peter Gibson showed in this lovely study from Australia that long-term azithromycin reduces exacerbation rates by 40%. And the benefits seem to occur across the board in type 2 high and type 2 low asthma, and are related to the amount of Haemophilus influenzae that is present in the sputum. You can see on the top right that the benefits of azithromycin become very large in patients who have high Haemophilus influenzae counts. So this again looks like it's a treatment for a treatable trait that you can recognize using sputum quantitative PCR. So just finishing on cough reflex hypersensitivity, I see an enormous number of patients who have a heightened cough reflex and who report excess cough frequency. And you can see here that when you assess cough frequency, these patients are not lying. They have between 10 and 100 times higher frequency of cough compared to normal healthy controls, and that most patients we see in the clinic have unexplained chronic cough. It's a problem particularly in women, so 2/3 to 75% of patients are women. And I was really struck by this proof of concept study published 6 years ago in the Lancet, showing that AF219, which is now called gefapixant, a P2X3 antagonist, has a really big effect on cough frequency in patients with unexplained chronic cough. And this compound is now through phase 3, and we're hoping will become a treatment for cough reflex hypersensitivity. So we have a number of traits that we need to look out for in the clinic and a number of emerging treatments that work specifically for those traits. And we discovered they're effective by pulling asthma and COPD apart and thinking much more in terms of treatable traits than arbitrary diagnostic labels. So I think the labels will probably slowly die away in this century. And we will reminisce to our grandchildren how we used to talk about asthma and COPD. And clearly there are much better ways of thinking about and classifying obstructive airways disease, which we need to start using. Thank you very much for listening.
Thank you, Professor Pawad, for that excellent talk. So we will actually take the questions once all 4 speakers have given their talks, and you can send it to us on Q&A. So let me introduce our next speaker, that is Dr. Manil Piris. Dr. Manil Piris is a senior consultant respiratory physician attached to the District General Hospital, Martale. Dr. Piris has a special interest in asthma and has contributed immensely to uplifting the care of asthma in Sri Lanka. So he's going to talk to us about GINA guidelines, what is new in 2020. Over to you, Dr. Piris.
Thank you very much, Chandimani. I hope I'm heard well. As I was mentioned earlier, I'm going to talk about the GINA guidelines and what's new in 2020. As everything in 2020 and probably in 21 is overtaken by COVID, all guidelines including asthma, have been overtaken by the COVID pandemic. And therefore, all guidelines now start with managing COVID with other diseases as well. So I will start with that as in the GINA guidelines. So asthmatics have respiratory symptoms. COVID also presents with respiratory symptoms, respiratory signs, low oxygen levels. And therefore, asthmatic patients should be advised on what they should do during this pandemic. And I think an important aspect is that we need to get these patients to continue taking their prescribed asthma medication, either it be inhaled corticosteroids, or if they are on oral corticosteroids, then still continue that, as stopping these treatments can lead to significant dangerous worsening of asthma and even lead to mortality and worsening of COVID as well. So for patients with severe asthma on biologic therapy, also we should advise them not to stop oral corticosteroids if they are on corticosteroids, and to reduce slowly. It is advised in all GINA guidelines over the last few years that a written asthma action plan is a valuable tool in the management of asthma. Unfortunately, in Sri Lanka, I think the use of written asthma action plans are few and far between. But of course, we have been advising patients on what they should do when their asthma worsens. And in this pandemic situation, I think we need to again revisit and think about giving written asthma action plans to our patients. And with our cultural background, we need to think of doing it in maybe in some different ways. So increasing the control and reliever medication when your asthma worsens is something which we advise our patients to do. It's part of the written asthma action plan, and taking short courses of oral corticosteroids for severe asthma exacerbations, and when they need to seek medical help should be a part of their written asthma action plan or part of the advice given to these patients. Most patients with asthma, when they come into hospitals in our setup, when they go to a doctor, into a GP, nebulization has been sort of the mainstay of treatment when they have exacerbation. But of course, in this pandemic situation, nebulizers increase the risk of disseminating virus because it is an aerosol generating procedure, and it can be unsafe for the other patients around them, as well as for the healthcare providers in the vicinity. So avoiding nebulizers as much as possible with use of pressurized metered dose inhalers, where a spacer is the preferred method during severe exacerbations, and use of a mouthpiece or tightly fitting face mask is what is recommended at this stage. Unfortunately, in Sri Lanka, we still don't have very much mouthpieces available in the government hospitals. And of course, what we have is the face mask. Another aspect we need to consider is, of course, spirometry. I think at the moment, most of our spirometry services have come to near standstill around the island, because these, again, are high-risk procedures, aerosol-generating procedures with danger to staff as well as other patients around. So it is recommended to postpone spirometry and peak flow measurement within healthcare facilities unless there is an urgent need. And we probably are doing patients who are going for urgent surgeries, major surgeries at the moment, but not for asthmatics. Also, many asthmatics who come with exacerbations go through various procedures in addition to nebulization, oxygen therapy, sputum induction, intubation, manual ventilation, and non-invasive ventilation methods, which can all be aerosol generating procedures, and we need to be very sure of what we are doing. Use of hygienic strategies, use of PPE, recommended PPE, and we need to be aware of the surroundings where we are doing these measures. So these are some things which we need to be aware of in this maybe couple of years or maybe even longer. So there's a lot of resources for COVID-19 as well as asthma, and in Sri Lanka, our college, the Sri Lanka College of Pulmonologists, have published their guidelines on COVID management, which has a section on asthma management itself. And of course, there's a lot of WHO recommendations, CDC recommendations, both for healthcare professionals as well as patients, which give a lot of information on this. And the national guideline on COVID management also has incorporated some of our guidelines which we have put in our guidelines. The key changes in asthma management actually started in the 2019 guideline, where it has been marked as a landmark change in guidelines of asthma. GINA now no longer recommends treating adolescents and adults with asthma with short-acting beta agonist alone, that is the salbutamol, which we use quite commonly. Instead, they should receive symptom-driven or a daily corticosteroid inhaler to reduce the risk of severe exacerbations, and that was what was there in 2019. And 2020 guidelines have underscored this fact even more, with more evidence coming in, and these changes are mainly brought about because of the fact that apparently mild asthma patients are at risk of serious adverse events. It has been shown that 30 to 37% of adults with acute asthma, 16% of patients with near-fatal asthma, and 15 to 20% of adults dying of asthma had very mild asthma, where they had symptoms less than weekly in the previous 3 months. So therefore, even therefore, it's vital that these serious events are avoided. Also, exacerbation triggers are very variable. We don't know at what time we get these triggers: viruses, pollens, pollution. Especially in Sri Lankan setting, we have indoor air pollution also, in addition to the external air pollution in form of various incense sticks and various forms of smoke, which are used more and more in the COVID pandemic as well, and poor adherence to treatment. Inhaled short-acting beta agonist salbutamol has been the first-line treatment for asthma for many, many years, over 50 years in fact. And this dates back from an era where asthma was thought to be a disease of bronchoconstriction, as you saw in the video at the start of the webinar. One of the major reasons which fuels the more and more use of salbutamol is that patients are very satisfied when they take the salbutamol. And it is again reinforced by the fact that they get rapid relief of symptoms. And when they come into hospital, we give salbutamol nebulization and in-hospital management with salbutamol, which reinforces the idea that salbutamol is the drug of choice in these patients. And therefore, the patients tend to believe my reliever or my salbutamol inhaler, it gives me good control of my asthma. But we need to get this paradigm shift from getting asthma and getting control to control of asthma long term, which will give you better quality of life. So we also know that regular and frequent use of salbutamol is associated with adverse effects. Beta receptor downregulation, which causes more and more beta agonists to be used, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response are some of the other effects. In addition, increased allergic response and increased eosinophilic airway inflammation is also seen with the frequent use of short-acting beta agonists. This leads to a higher risk of adverse clinical outcomes with regular short-acting beta agonist use. It has been shown that 3 or more canisters of salbutamol use per year is associated with a higher risk of emergency department presentations, and dispensing or using of 12 or more canisters per year is associated with higher risk of death. So therefore, the GINA guideline has been actively seeking interventions for mild asthma. As Professor Ian mentioned, these studies have been going on for a long time, and at last, I would say, they have come into the guideline in this form. So the main thrust is to reduce the risk of asthma-related exacerbations and death, and to provide a consistent messaging about the goals of asthma treatment, including prevention of exacerbation rather than treating when you get exacerbation. So we need to also get the message across that patient reliance on short-acting beta agonists needs to be reduced so that they have better quality of life. So therefore, lots of studies have been done, and some of those studies have been shown already by Professor Ian in his lecture. So therefore, GINA no longer recommends short-acting beta agonist as the only treatment for step 1, which has been the hallmark of treatment over the last decade or so. This decision was based on evidence that short-acting beta agonist only treatment increased the risk of severe exacerbations, and adding any inhaled corticosteroid significantly reduces the risk. GINA now recommends that all adults and adolescents with asthma should receive ICS, that is inhaled corticosteroid containing controlled treatment to reduce the risk of serious exacerbation. So the inhaled corticosteroid can be delivered by regular daily treatment, or in very mild asthma by a as-needed low-dose inhaled corticosteroid and formoterol-based combination. This is a population risk reduction strategy has been employed in other conditions like in the use of statins and antihypertensives in cardiovascular disease. Individual patients may not necessarily experience short-term clinical benefit with this, may not be aware of it, but we need to show them that in the long term, they have a much better quality of life and therefore will be benefited by this using the inhaled corticosteroid rather than the short-acting beta agonist. The main goals of the asthma treatment in GINA have been personalized asthma management. It has been the three main thrusts has been to assess the patient's control, adjust the dose, review the patient again, reassess, readjust the dose. And that has been a consistent part of the GINA guidelines over the years. And this is not just medication alone, and we need to personalize the management of the patient, as one size does not fit all. So therefore, we know the stepwise approach in asthma has been the one which has been used maybe over a decade now. And of course, the major changes occurred in 2019. Step 1 management, as I said earlier, we now use as needed low-dose ICS formoterol combination can be used, or low-dose inhaled corticosteroid taken whenever a short-acting beta agonist is taken in step 1, rather than in the previous guideline, it was a short-acting beta agonist, salbutamol, which was used as and when needed. Step 2 is for daily low-dose inhaled corticosteroids, or as needed low-dose inhaled corticosteroid formoterol combination, or in otherwise we can use the daily leukotriene receptor antagonist or low-dose inhaled corticosteroid taken whenever a short-acting beta agonist is taken, as in the step 1 if they have no symptoms. Step 3 is low-dose inhaled corticosteroid and long-acting beta agonist together. But in case they cannot use a long-acting beta agonist, medium-dose inhaled corticosteroid or a low-dose inhaled corticosteroid with leukotriene antagonist can be used. In step 4, we go for a higher dose a medium dose of inhaled corticosteroids with combination with LABA, and or in otherwise we can use a high dose inhaled corticosteroid with add-on tiotropium or add-on leukotriene antagonist. As we heard earlier, the phenotypic the different phenotypes in asthma may govern the choosing of these various other measures rather than on the traditional ICS-LABA combination. And of course, the step 5 is the ICS-LABA high-dose ICS combination, and with add-on therapy with tiotropium and the anti-IgE, anti-IL-5 and anti-IL-4 therapy. Or instead of that, in some patients, we have few patients who are on add-on low-dose oral corticosteroid, but we need to be aware of their side effects. Another major change is the relievers. As you can see here, the preferred reliever over the decades has been the short-acting beta agonist alone, but we now have, as needed, low-dose inhaled corticosteroid with formoterol combination can be used in this area, as well as it can be the same thing, can be used as the controller, as well as a maintenance maintenance dose, as well as a reliever. So that has been one of the major changes in the management of bronchial asthma in the stepwise approach to the management. I think these studies were mentioned by Professor Ian in his presentation, where it was shown very clearly that low-dose budesonide formoterol in mild asthma shows a significant reduction in severe exacerbations versus SABA alone and versus maintenance inhaled corticosteroids, with a small or no difference in symptom control and lower average ICS dose. So therefore, these are some of the studies which have been promoting this sort of management. All these studies also use the inflammatory markers which were mentioned in the earlier lecture, like FeNO was significantly reduced by as needed ICS formoterol combination, which he showed a very nice slide earlier. So therefore, these are the new methods which we have been used to make these changes into the guidelines. Although these have been known for some time, as mentioned by Professor Ian, coming into the guidelines, it has taken a long time. In children, 6 to 11 years of age, again, step 1, we now have low-dose inhaled corticosteroids taken whenever SABA is taken, rather than SABA alone, or daily low-dose inhaled corticosteroid is advised as being preferable to giving inhaled salbutamol as a single drug as needed. In step 2, you have the daily low-dose inhaled corticosteroid, and in place of that, you can also use daily leukotriene receptor antagonist or low-dose inhaled corticosteroid taken whenever when a short-acting beta agonist is needed. In step 3, you have low-dose inhaled corticosteroid, LABA combination, or a medium-dose inhaled corticosteroid as the preferred drugs, or you can go for a low-dose inhaled corticosteroid with leukotriene receptor antagonist. Step 4 is a medium dose of ICS-LABA combination, and of course you can go on to higher dose inhaled corticosteroid LABA or add-on tiotropium, which has been is a new addition in the 2019 guideline, going on to the 2020 guideline. Also in step 5, in this age group, anti-IgE therapy has now come into the guidelines. and can be used. Unfortunately, we still do not have them available in Sri Lanka. And I think in the near future, we will have the relievers for this age group changing as well. But at the moment, as needed short-acting beta agonists probably used with inhaled corticosteroid would be preferable. So another new addition to the 2020 guideline is answers a very difficult question which many people had. That is, how are you going to start treatment on when we diagnose a patient with asthma? How do we start it? What is the drug step we are going to start these patients with? Are we going to start at step 1 and go up, or start at step 5, step 4 and come down? Or what is the best way to do this? So 2020 guideline comes up with this very nice diagram for stepwise management of treatment with suggested initial control of therapy. So if you have symptoms less than twice a month, you go for step 1. Symptoms twice a month or more, but less than daily, then you go for step 2. Symptoms on most days or waking with asthma once a week or more, you go for step 3. But if you have more and more symptoms daily with waking with asthma once a week or more, and also you have low lung function, then you go for medium dose, the step 4 management. And in this step, also you would consider giving them a short course of oral corticosteroids to give them quick, good control to start them off with a better control step. Again, of course, the reliever medication is the same. So I think this is a new addition to the very important addition to the 2020 guideline. In children, again, symptoms less than twice a month, you go for step 1. Symptoms twice a month or more, but less than daily, you go for step 2. Symptoms on most days or waking with asthma once a week or more, you go for step 3. And symptoms on most days or waking with asthma once a week or more, and low lung function, you go for step 4. So you start with that step, then go give them the treatment, reassess, and then redo the management depending on their control. What is another question we get from our patients is once we tell them, okay, you are on budesonide formoterol maintenance therapy, but if you get exacerbation of asthma, take additional doses of the budesonide formoterol you're using. The question they ask is, how many times can I take this? How often can I take this? What is the evidence for that? Well, from the product information, the maximum recommended total dose of formoterol is 72 micrograms per day. Going on to a turbohaler, it would be around 12 inhalations. In Sri Lankan equivalents in the MDIs, we have with budesonide formoterol maximum of about 12 puffs a day. That's quite a lot. And dry powder capsules, which we have around 12 caps a day, depending on, of course, the dose in the capsule. There are 2 doses we have in Sri Lanka at the moment, so you need to check the doses when you are prescribing which capsule. So that is somewhat of a guide to how much you can give. But of course, we need to always tell these patients, if you take additionally and you're still not responding, please go to your doctor or the healthcare facility closest to you if you're not responding with additional 1 or 2 doses. Low-dose beclomethasone formoterol combination is also now available in Sri Lanka. Can be prescribed as a maintenance and reliever therapy within asthma action plan. On the product information, the maximum recommended total in 1 day is 48 micrograms of formoterol, which works out to about 6 inhalations of the beclomethasone formoterol combination of 100 by 6 formoterol. So these are some of the things which we will need to inform the patient. If you have a written action plan, these are the things which we have to record in that. Another important aspect in the management is how we are going to assess the symptom control, and these have been the 4 questions, which are very easy questions to ask in the clinic to assess your patient's asthma control. Do you have daytime symptoms more than twice a week? Any night waking due to asthma? Do you use a reliever, which is a short-acting beta agonist, for symptoms more than twice a week? Or any activity limitation due to asthma? If you score no in all of these, none of these, you're well controlled. If you have 1 or 2 yes in this, you are partly controlled. And if you have 3 or more, then of course you are poorly controlled. The problem we have is, can we take the reliever of ICS formoterol as used in this? At the moment, the GINA guideline says studies are continuing to confirm this. I think it probably is, but we need to wait for further clarification in the next guideline. Another major event in 2020 guidelines was this FDA warning for montelukast, which talked about serious mental health effects of asthma and allergy with the use of these. Earlier, there were some studies which showed that there was increased suicide risk in adults and adolescents, but subsequent reanalysis of them, probably those not related to the montelukast, but of course still there is this warning for mental health side effects, and if the patient has any of them, it's better to avoid. Difficult to treat and severe asthma have made vast changes in the new guidelines, but I'm not going to talk about them as we have another lecture on this. And the major drugs which we use are the anti-IgE, anti-IL-5, and anti-IL-4. We still don't have these drugs in Sri Lanka, but as Professor Ian talked about them, blood eosinophil counts being higher is one of the indications to use this in patients who go on to step 5. So in summary, I think we have made great strides in asthma control, and the GINA guideline re-emphasizes the landmark changes in asthma management made in 2019. Use of short-acting beta agonist salbutamol only is discouraged. That is, use only as a single drug is discouraged and is harmful, and it encourages use of inhaled corticosteroids with long-acting beta agonist as a controller and reliever, or ICS with SABA when needed. Thank you very much.
Thank you, Dr. Piris, for that comprehensive lecture. I'll introduce our next speaker. He's Roland Leung. He's an associate professor from the Department of Pediatrics, Chinese University, Hong Kong, and an honorary lecturer in Macau University of Science and Technology Medical School. He's a practicing respiratory physician at Hong Kong Sanatorium and Hospital and Hong Kong Adventist Hospital. He has held many important posts in the region. And he has over 50 original papers in peer-reviewed journals, over 60 abstracts in international conference proceedings and journals, and over 150 invited lectures. I invite Dr. Liu to give his lecture on effective strategies in managing severe asthma and difficult to control asthma. Over to you.
Thank you. Thank you very much for that kind words of introduction. And it is indeed my pleasure this evening to be able to participate in the asthma webinar today. Now, what I would like to do over the next 25 minutes or so is to give you my take on how to approach the management of patients with severe asthma. Now, we just heard a wonderful presentation by Dr. Manu on the current update on GINA guideline in asthma management. And all of you are familiar with the guideline, which basically provides a framework of how to escalate or de-escalate asthma therapy according to disease severity in order to reach asthma control. But in the real world scenario, asthma control is far from ideal. This study coming from Europe assessed current asthma control in 7,500 asthmatics using GINA criteria and found that nearly 45 to 50% of asthmatics had uncontrolled asthma, which means under the umbrella of asthma control in clinical practice, we have patients who have very well-controlled asthma, as well as those with uncontrolled asthma. But for patients with uncontrolled asthma, if we can follow the GINA guideline to escalate the asthma therapy and so on, we can easily bring them back to control. However, that remains about 5 to 10% of asthmatics whose asthma are very difficult to control, and we call this severe asthma. And this is what we're going to focus on for the rest of my talk today. Now, the definition of severe asthma by ATS and ERS is that asthma which requires treatment with guideline-suggested medication, such as high-dose inhaled corticosteroid and LABA for the previous year, or they require systemic corticosteroid for more than 50% of the previous year to keep the patients under control, or the asthma which remains uncontrolled despite this therapy, which means that these patients continue to have significant asthma symptoms, frequent exacerbation that require hospitalization, or oral corticosteroid, and have limited airflow on their lung function testing. So it was estimated that about 340 million people have asthma worldwide, and about 1 in 10 of these patients may have severe asthma. That amounts to 34 million people. That's a lot of people. And we know that people with severe asthma have worse outcome. They have more frequent exacerbation, that they have 10 times higher risk of hospitalization, 8 times higher risk of death, and certainly they have very poor quality of life. And in particular, patients with a severe eosinophilic asthma phenotype, as Dr. Pawad has very eloquently presented to us early on today, that these severe asthmatic, they are 5 times more likely to require health care. So when we are confronted with a patient with severe asthma, we should sit back and try to deconstruct asthma into components, which we can easily identify and assess and manage individually so as to complete the asthma control. Now, Professor Pawad has mentioned about various treatable traits, including cough reflex, hypersensitivity, different kinds of airway inflammatory phenotypes, airway structure, and so on. And for my clinical experience, I want to make sure that I know the patient are using the correct inhaler with the correct inhalation technique. I think that's very important. I would go and look for comorbidities which may contribute to poor asthma control. And of course, asthma, the airway inflammation that's driving asthma needs to be determined so that I can plan biologic therapy if they are appropriate. Now, many of you would agree with me that many patients indeed with airways disease, they fail to use inhalers correctly. And studies have shown that between 75 to 90% of patients, they make at least one error in using either MDI or DPI. And GINA also recommends that if patients' asthma is not well controlled, the first thing we should check is their inhalation technique. However, even if the patients are using the right and correct inhaler with good technique, adherence remains a problem, like any other chronic diseases, like asthma, diabetes, and hypertension. That patients tend to forget using their medication as prescribed. And studies have shown that up to 50% of patients prescribed the inhaler for their asthma control fail to do so after about 40 days of use. And by the end of 1 year, only about 10% of patients continue to use the inhaler as prescribed. So if we can somehow improve the adherence rate to asthma, we can already bring some of these patients back to control again. Now, comorbidities are important. And the most common comorbidity that we find associated with asthma is that of allergic rhinitis or rhinosinusitis, that up to 70% of asthmatics are said to have some degree of upper airway problem as well. And I look for this quite aggressively myself and treated with with nasal steroid, antihistamine, and so on. And at times we would refer the patient to ENT surgeon to consider even sinus surgery, because we know that the reduction of postnasal drip sometimes could improve asthma control, although the literature does not support that treatment of AR necessarily lead to better asthma control. I think clinically it is a very important association. OSA is common, is said to occur in anywhere between 50 to 80% of patients with severe asthma, particularly in the obesity phenotype. And that contributes to poor asthma control and nocturnal symptoms. Asthma exacerbation is said to increase by some 3 to 4-fold in patients with OSA, and treatment with CPAP have been shown to improve asthma control as well. Gastroesophageal reflux is common, more so amongst Caucasians than Asians, but more in Asian population nowadays that the diets become more westernized. It is particularly useful in the cough variant asthma that patient present with nocturnal cough, maybe due to silent reflux during night sleep. The role of proton pump inhibitor in asthma control, however, remain unproven, but there are patients who certainly have improvements of their asthma control if they have ongoing severe esophagitis. After treating them with PPI, they do have better nocturnal symptoms improvement. Psychiatric disorders are said to common as well, said to be present in about 25 to 45% of patients with severe asthma, mainly with anxiety, depression. And this kind of psychiatric disorder can also increase exacerbation and hospitalizations in this group of patients. Drugs, we had before, ACE inhibitor, beta blockers, and in particular, non-steroidal anti-inflammatory medication could lead to asthma exacerbation in those who are sensitive, and they are usually associated with nasal allergy as well. Now, of course, when we confront a patient with severe asthma who do not respond to conventional therapy, we have to sometimes ask ourselves whether we have made the correct diagnosis, because we have to remember not all wheezes are asthma. Maybe some of the asthma mimics are what is going on that we need to identify them with. For example, patient may have predominant COPD, particularly if the asthma symptoms are of late onset in the male who are a heavy smoker. On the other hand, if the uncontrolled asthma symptoms occur in a young female who also present with inspiratory stridor as well as expiratory wheeze, we've got to consider this possibility of vocal cord dyskinesia, or sometimes called inducible laryngeal obstruction. And if we manage to do a lung function test during the attack, we can sometimes see flattening of the inspiratory flow volume, which is quite characteristic of upper airway obstruction as well as lower airway problem. Other uncommon conditions that can mimic asthma or in association with asthma include allergic bronchopulmonary aspergillosis. These patients tend to present with bilateral upper lobe infiltrates and sometimes even bronchiectasis. They have elevated total IgE levels, and in particular, specific IgE levels of Aspergillus fumigatus also elevated. Pulmonary vasculitis uncommon, but the Church-Strauss syndrome sometimes can occur in asthmatics associated with blood eosinophilia and sometimes transient lung infiltrates on chest X-ray. Now, hyperventilation is quite common in at least in my clinical practice. The patient complain of dyspnea. They find it's difficult to take a deep breath all the way to the bottom part of the lungs. They have to decompress the lung by coughing before they can breathe again. And that is often associated with some kind of a panic attacks. So patient may present with insomnia, palpitation, and other symptoms associated with anxiety. Congestive heart failure and so-called cardiac wheeze, of course, is well known to everyone. Patient with fine crepitation, on auscultation, and they have impaired cardiac function. And different causes of airway obstruction by fixed airway obstruction by the bronchial lesions in the upper airways and the lower airways sometimes can mimic asthma, and that needs to be looked for. So when patients have severe asthma that are not responding to conventional treatment, we might have to do some additional investigation in order to identify less common morbidities and differential diagnosis contributing to asthma symptoms and exacerbations. And these investigations may include blood tests. We can check the CRP, C-reactive protein, to find out whether there's any inflammatory condition going on, like infection or autoimmune diseases. We can check the total IgE levels and specific IgE to Aspergillus if you suspect ABPA to be a possible differential diagnosis. Allergy testing should be done to identify culprit allergens by the skin prick test or blood test, because exposure to specific allergen can lead to poorly controlled asthma. Other investigation may include lung function tests with DLCO if you suspect COPD or emphysema, as opposed to asthma. Chest X-ray or high-resolution CT scan allow us to pick up bronchiectasis like ABPA and so on. Other directed testing includes CT sinuses or cardiac investigation. Now, just to mention about testing for parasitic infestation, one needs to be aware of this because we know that parasitic infection can cause blood eosinophilia, particularly in populations where such infections are endemic. And if one is considering using type 2 targeted biologic therapy, this should be checked because type 2 therapy in a patient with untreated parasitic infestation could potentially lead to dissemination of the disease. So, so this is one thing that one has to bear in mind. So now when it comes to the airway inflammation, we have heard from Professor Pawad on his explanation of how the eosinophilic airway inflammation is important. And Gina also suggested if patients have persistent symptoms and exacerbation despite high dose inhaled corticosteroid, then we should try to identify the inflammatory phenotype. And we have heard that the type 2 inflammation is most common, most relevant, and is said to be found in about 50% of patients with severe asthma. It's characterized by cytokines such as IL-4, IL-5, IL-13, which are often produced by the adaptive immune system upon recognition of specific allergens. At the same time, viruses, bacteria, irritants, and other environmental exposure may interact with the bronchial epithelium via the innate immune system, producing IL-33, IL-25, and the thymic stromal lymphopoietin, or TSLP, by epithelial cells. Now, this cartoon has been shown before. I won't bore you with much detail, but only to show that the allergic eosinophilic airway inflammation is depicted in green on the left, whereas the non-allergic eosinophilic airway inflammation is shown here in red on the right. The end result of both pathway is the production, maturation, and differentiation of eosinophils, and that can directly cause airway inflammation. So that we also heard already that the biomarker, which is very useful in determining type 2 inflammation, is that of blood eosinophilia or increased phenol. Sometimes patients may have accompanying atopy, whereas the non-type 2 inflammation is often characterized by increased neutrophils, so-called neutrophilic asthma. In many patients with asthma, type 2 inflammation can indeed be rapidly responsive to inhaled corticosteroid therapy if they're taken regularly. So these patients tend to have mild or moderate asthma. Whereas in severe asthma, type 2 inflammation may be relatively refractory to high-dose inhaled corticosteroid and require oral steroid control. So therefore, if we suspect patient have refractory or and severe asthma due to underlying type 2 inflammation, the biomarkers that we should look out for, just to reiterate, blood eosinophil counts of greater than 150, or the FeNO greater than 20 units, and sputum eosinophils of greater than 2%. And this would be the biomarkers that most labs around the world use nowadays. Now, Professor Pawad has also mentioned about the correlation of blood eosinophilia with asthma exacerbation, acute respiratory event, that they have a positive correlation quite nicely shown in this meta-analysis of some 68,000 patients with asthma aged between 12 to 80 years. And it has a negative association with overall asthma control, that as the eosinophil counts in the blood increases, the asthma control became worse and poor. And biologic therapies target key pathway in the pathogenesis of allergic and non-allergic asthma. We have heard already that IL-4, IL-5, IL-13, IL-4 are the three main interleukins that are associated with the eosinophilic airway inflammation. Total anti-IgE, of course, should be mentioned as well, because perhaps it's the oldest biologic therapy that's been around. It binds to the free IgE, reducing the amount of free IgE that is available to treat allergic diseases. But of course, the IL-4 and IL-13 inhibitors, we heard about dupilumab, and IL-5, mepolizumab and mesulizumab, and anti-IL-5 receptor, benralizumab as well. In the GINA guideline, it specifically mentioned anti-IL-5, anti-IL-5 alpha and anti-IL-4 alpha as the available biologic therapy that we can use to treat severe asthma. Now, mepolizumab, we have heard already, is a humanized monoclonal antibodies of the IgG1 type. It inhibits the IL-5 signaling and reducing the production and survival of eosinophils. Benralizumab is an IL-5 receptor alpha antagonist. It's an IgG of IgG1 subtype. It binds the IL-5 alpha unit, and it enhances the so-called ADCC, or antibody-dependent cell-mediated cytotoxicity, which then lead to apoptosis of eosinophils and depletion of eosinophil counts, perhaps more so than what mepolizumab can do. Dupilumab is also a monoclonal antibody of IgG4 subtypes. It directs and inhibits IL-4 and IL-13 binding, and leading to reduction of release of pro-inflammatory cytokines, chemokines, and IgE as well. Now, what are the predictors of good response to these biomarkers? For anti-IgE, we like to see patients with atopy. They have early onset asthma, perhaps together with eczema, and as well as allergic rhinitis, and patients people with high blood eosinophil counts and high FeNO tend to respond well to anti-IgE. For anti-IL-5 therapy, high blood eosinophil levels is a useful marker to predict good response. Patient with a lot of exacerbation. We have heard from Professor Pawad that eosinophilic inflammation is particularly important in driving the exacerbation in this patient. Patients with asthma of adult onset and nasal polyposis tend to do well on IL-5 therapy as well. I will show you a case shortly after this, and to illustrate this point further. Anti-IL-4R or dupilumab, patient with high blood eosinophil counts and high FeNO tend to respond well to this therapy. Now, we heard about mepolizumab already, that it is indicated for patients with severe asthma and peripheral blood eosinophil counts of more than 150, and it's been approved for use for patients aged 12 and over. And it blocks the IL-5 action on eosinophil recruitment, maturation, activation, survival, and reduces the frequency of exacerbation of severe refractory eosinophilic asthma patient. Benralizumab, on the other hand, as I mentioned, it has a what we call a fructosylation. That means a removal of a fructose residues in the oligosaccharide side chain will allow increased attachment enhance the attachment onto the cells and leading to ADCC, so that it has the ability to deplete eosinophils that express IL-5 receptors. And that, in fact, in part would allow less frequent dosing of this drug because it depletes the eosinophil count so low that you can give the drug every 8 weeks after loading dose of 3 months as opposed to every 4 weeks. And this is a unique action of benralizumab over mepolizumab. Now, in the real-world response recently published last year in Chest, that benralizumab has been shown, like mepolizumab that Professor Pawad has shown you, that after therapy of a year, it reduces asthma exacerbation rate, it improves asthma symptoms and quality of life, reduce asthma symptoms and improve quality of life rather. They improve lung function. Everyone here increased very nicely after 3 months, 4 weeks, and reduction of oral corticosteroid use from a mean of 10 milligrams before the injection, before the therapy, down to nothing after about 48 weeks of therapy. And in particular, in this study, it has been shown to reduce exacerbation up to 85%. The interesting thing is that it is effective in reducing exacerbation in both biologic naive patients, that is, patients have not received biologic before, as well as those who have experienced a biologic of another type before. The reduction of exacerbation rate is very similar. And the onset of effect can be observed as early as week 16 and is maintained throughout the 48 weeks period without any tachyphylaxis as such. So to sum up what I have just briefly mentioned about my approach to management of patients with severe asthma, I want to show you a case that perhaps would wrap up some of the points I have made in the last few minutes. Now, this is a patient, now 67-year-old male, non-smoker, non-drinker, has some mild seafood allergy in the past. He has history of allergic rhinitis, pansinusitis, nasal polyps, and had received polypectomy in the past. His asthma started when he was about 20 years of age, so sort of early age onset. He was on high-dose LABA, ICS combination, montelukast, tiotropium, and maintenance corticosteroid for about 10 years. Drug compliance has been good all along. His blood test showed he has chronic eosinophilia, level of 0.8 to 2.5. It's always been elevated. And we look for other potential differential diagnoses. We found that the anchor antibodies ANA were negative, skin prick test was negative, IgE level was normal, aspergillus serology was also negative. There was no signs of a parasitic infestation. Heart seemed to be normal, and there's no evidence of vasculitis. So this basically echo what I mentioned about common comorbidities and what are the other alternative diagnoses one has to think about when someone's asthma has been so poorly controlled despite the use of maximal medication according to GINA guideline, as well as the use of oral corticosteroid for such a long period of time. Of course, the interesting point is the chronic eosinophilia that he's had for the last 10 years. So he had recurrent asthma exacerbation despite maintenance, and he was most recently given prednisolone 7.5 milligrams daily as maintenance and other GINA level 5 medication. And despite that, he still required, he still had exacerbation that required the use of oral corticosteroid for 6 to 7 times per year. Most of these attacks were precipitated by a concurrent upper respiratory tract infection or when weather changes to cold climates. There's not been any growth of bacteria from his sputum ever. His drug compliance was good. So I mentioned that the first thing I wanted to make sure the patient are using correct inhaler, but he was very compliant with his medication. Inhaler technique has been checked and it's been reinforced and it's okay. And there was no other specific environmental factors that we could identify that could precipitate his symptoms. His rhinitis well controlled. There's no gastroesophageal reflux. And this is the list of medication he was on. He was on combination of budesonide formoterol, tiotropium, montelukast, theophylline. He was using nasal steroid and oral corticosteroid. But he continued to have significant asthma symptoms and impaired peak flow and impaired lung function test. Clinically, he was dyspneic, he was hypoxic on room air. He had wheezed bilaterally, no peripheral edema, suggests cold pulmonale. Cardiovascular examination was normal, and there's no sign of mononeuropathy that could go with vasculitis syndromes. Now, this is his lung function. You can see that his FEV1 was only 29% predicted at 0.7 liter, and the FVC is 65% predicted, very obstructed spirometry. Chest X-ray showed a bit of hyperinflation and with no signs of bronchiectasis or infiltrates in the lungs. His peripheral eosinophil counts have always been elevated, 600 to 700 up to 1,200 over a period of a month. Blood gas was normal, total IG level was normal, so he's not the typical allergic type of individual with elevated total IgE levels, because his asthma onset wasn't in childhood, where you would tend to see eczema and allergic rhinitis in very much elevated total IgE levels. So the diagnosis, therefore, that patient has severe eosinophilic asthma based on the chronic blood eosinophilia. And the option of anti-IL-5 therapy was discussed with him, and then we decided to start him on mepolizumab, 100 milligrams subcutaneously every 4 weeks. That was started in August 2018, and about the time when mepolizumab was first launched in Hong Kong. Now, this summarizes his clinical and laboratory response to mepolizumab therapy over a period of 12 months. You can see in this column here of the eosinophil counts that it came down from 1.14, 1,100, down very rapidly, down to less than 200 within a month, and then was maintained at a very low level, less than 100 throughout the rest of the course of therapy. His V1 was 0.7 to start off with, but very shortly after the therapy was given, his lung function has improved dramatically, that his FEV1 increased from 0.7 to 1.4 liters within a matter of months, and then it was sustained and maintained throughout the rest of the course of therapy, so that his FER remained about 50%. His asthma symptoms improved with an ECD score from 14 up to 21, and then nearly full marks for the rest of the time. He has 6 major exacerbations that required oral corticosteroid therapy before mepolizumab was started, but since then he had no exacerbation at all, and that's quite remarkable. And the oral corticosteroid dosage was successfully weaned from 7.5 milligrams maintenance that he was on for a long time, down to 3 milligrams after 9 months, and recently we swapped over to hydrocortisone 5 milligrams only. The other asthma medication, he was using GINA-5 medication plus Spiriva and theophylline, and then after 3 months, he was only using ICS-LABA combination. He developed a bit of a vasculitic rash on his leg about 3 months after the injection, and it was healed with topical steroid. We think that could be this could be one of the side effects of mepolizumab causing mild rash on his body. So the side effects, as I mentioned, is drug-induced skin rash and a little bit of headache and non-specific myalgia. That's about all. And he tolerated the treatment very well. His FEV1 was stable throughout 1.5 liters that I've shown you. So the patient gained a terrific and excellent recovery, if you like, from mepolizumab. His asthma became so well controlled that he decided to take a drug holiday. He thought that, well, you know, I had 12 months of therapy, and of course it's also very expensive. So he took a break from mepolizumab. And we found that after 3 months of stopping mepolizumab, his eosinophil count jumped right up from 70 to 1,400 within 3 months. And his symptoms start to return. He has increasing asthma exacerbation and had 3 major attacks in the subsequent 6 months that require hospitalization. So it's a marked rebalance of both eosinophil counts and asthma symptoms. So the patient then decided to go back on biologic therapy, but this time he opted for benralizumab in view of the anti-IL-5 or mepolizumab-induced skin rash, and that, as I mentioned before, IL-5 benralizumab, because of its ability to cause apoptosis of eosinophils, it can deplete eosinophil counts. That expresses the IL-5 receptor more, so that can be dosed more infrequently, so every 8 weeks instead of every 4 weeks. So because of that regimen, he found this more convenient, so he decided to go on that. So therefore, he has 3 months of monthly or 4-weekly benralizumab, followed by Q8 weeks or 2 months of every 2 months therapy thereafter. And you can see that his eosinophil counts was markedly reduced to really undetectable after 1 month or after 1 injection. His lung function also improved, that his FEV1 has improved from 1.12 to 1.7 after 3 months of therapy. His symptoms were controlled. He had no more exacerbation after he swapped over to benralizumab therapy. The maintenance steroid, again, from 7.5 was able to be weaned to 2.5 milligrams after 6 months. And he just stayed on the GINA 5 guideline therapy, including ICS and LABA combination, and he had no side effect. So I think this case is interesting that he was initially on mepolizumab with good response. He took a drug holiday for 3 months, and the eosinophil count jumped up, his asthma syndrome came back, and he had frequent exacerbation, and decided to go on with benralizumab therapy because it doesn't cause the skin rash that he sustained from mepolizumab, and then it only required every injection every 2 months instead of every month after a build-up phase of 3 months. So therefore, both anti-IL-5 and anti-IL-5 receptor antagonists were able to help wean the oral steroid down to physiological dose and help control the asthma symptoms in this patient. So as Professor Pawad has mentioned, that besides IL-5, IL-4, and IL-13 that we have spent some time talking about, there are other therapy along the pipeline which are more upstream of the allergic or the inflammatory cascade, and that directed towards the chemoattractant receptor on the Th2 cells and anti-TSLP. But of course, these data are not out yet, and we'll be looking forward to more data coming out. And of course, what I've been talking today as far as biologic therapy is concerned is mainly towards eosinophilic asthma. As Professor Pawad has mentioned, there are other treatable traits and other phenotype that has been identified. And hopefully in the next few years, we will see more and more therapy that become available so that we can treat this problem more efficiently. Okay, I would like to end here, and thank you very much for listening. Thank you.
Thank you, Professor Leung. So we'll move on to our next speaker. It is my pleasure to introduce our final speaker, Dr. Niranjan Desanika. He's a consultant respiratory physician currently working at the Teaching Hospital, Ratnapura. Niranjan, to his credit, has given many invited lectures in the local and overseas fora. And today he will talk to us on asthma in special patient populations. Over to you, Niranjan.
Okay. Thank you very much, Chandimani, for your kind introduction. I hope that the screen and my voice is clear. And it is indeed a pleasure to be a part of this webinar. And I would be talking to you about 3 important patient groups in asthma, exemplifying the importance of understanding that asthma is a it is very important to understand the underlying psychosocial behavioral aspects as well. So first of all, we will discuss about the plague that we have, not COVID, but it is obesity. And around that means 1 out of 2 of adult population is obese, and in statistics, out of 10 are obese. And when you look at the last 45 years, the amount of obesity in our population worldwide has almost tripled. Now, when you look at in the Sri Lankan context, we are not immune to this aspect as well, because a study done in urban areas has shown again that 1 out of 3 of us are overweight, and abdominal obesity, that is a measure of adiposity, was about 60% common, especially in these urban population groups. So obesity is a worldwide problem as well as a Sri Lankan problem. Now, do we have any association with obesity and asthma? Usually this dark line is the asthma obesity prevalence of America, and you can see that almost parallelly the asthma prevalence has also risen according to the obesity prevalence, giving rise to postulation that when obesity increases, there is an increasing of asthma. Now, this has been shown in several studies. The meta-analysis has been done, and in most of these studies, they have been showing that having obesity is a risk factor for asthma, and the odds ratio can range from about 1.4 to 3, depending on the study group that you are studying. And especially in patients who have gained about more than 5 kilograms within a 4-year lifespan are more prone to get asthma than people who have not. And especially when the BMI is more than 31, males have an exponential males. Now, these are actually reported symptoms that we have used to diagnose asthma, except for this study, which has actually confirmed the asthma by bronchoprovocation. It has shown that almost 3-fold rise in obese patients than non-obese patients. All of the other studies, most of them are, depending on the the patient self-reports as well as other surveys that have been associated with the when we are calculating the prevalence of asthma. But even there, we can confidently say that, especially when we have used ideal mechanisms to identify obesity and asthma, the relationship, there have been proven associations improving the, increasing the odds ratio for about 3. One important aspect of patient reporting symptoms and diagnosing asthma is that obesity, in patients with obesity, the tendency to diagnose asthma is more prevalent. That is, overdiagnosis is more prevalent in obese patients, and almost 1/3 of the obese patients who have been previously diagnosed as asthma did not have objective evidence of asthma. And especially when you are morbidly obese, about 40% did not qualify for having current asthma. So that is a very important aspect, because obese patients can have symptoms similar to asthma, like shortness of breath and tiredness and chest tightness because of deconditioning. And they don't, and some of them have GORD, some of them have diastolic cardiac failure and obstructive sleep apnea causing pulmonary hypertension. So especially, we have to think about these aspects, especially before we diagnose asthma in obese patients, even though obesity and asthma go in hand. Other one aspect is that when you are obese, you have more severe asthma. Especially when you are obese, you have a tendency to admit to a hospital 6 or 7 times more than a non-obese patient. And at the same time, the likelihood of having less controlled asthma is more. And importantly, usually the normal treatment that we give for asthma is corticosteroids. And in obese patients, this asthma patients with obesity are corticosteroid naive sometimes, and they don't respond, especially because of the cytokines that are secreted by the adipose tissue, causing an reduction of the induction of mitogen kinase activities, phosphatase 1 activity. And we know that mitogen activated kinase phosphatase is a very important signaling protein that is needed for the actions of glucocorticoid hormones. So in a way, obesity people are more prone to get asthma, and they are prone to get more severe asthma. And unfortunately, some of them are not, therapeutically liable for the normal treatment. And especially this doesn't end there. We have, especially when you have maternal obesity, especially with the weight gain during pregnancy, the offspring has a high predisposition to develop asthma as well. So if I go to this graph that was shown by Professor Pawad earlier, now there is a typical phenotype that has been identified here, the obese non-eosinophilic asthma, where there is a significant amount of symptoms with less eosinophilic inflammation, which is characterized by the later onset female preponderance. But whether it is only the type of asthma that we have is a questionable thing. Yes, we have the de novo asthma arising consequent to obesity, but we have the usual asthma phenotypes complicated by obesity, especially because these patients tend to have overuse of steroids, as well as they don't have physical activity as we should like to. And then you have the uncontrolled worsening asthma with severe asthma. So how can we explain that? So when you look at the physique of the asthma patient, you can see a lot of adipose tissue surrounding the thoracic wall as well as the abdomen, and this results in constricting the thoracic wall as well as reducing the compression of the diaphragm, and then it will reduce the compliance of the chest wall, where you will have difficulty in breathing, and these patients takes shallow rapid breathing closer to the end residual volume. And these patients have a tendency to have, as you have increasing amount of BMI, the expiratory reserve volume is low, but even though the functional residual capacity will also be low. And what happens there is that these patients, because of these airways are in the lower volume area of the lung, where the airways tend to be narrower than in a normal person, these the connections between the actin and myosin are more tight, and it will take more physical force to separate them, and this separation will cause a mechanical type of injury that might be one of the causes of obesity, causing increasing amount of bronchospasm. Atopy has not been proven to be associated with bronchial asthma except in girls, and inflammation has been shown to be associated, which I will be going to in detail, especially about adipokines. Even though we say obesity, I think it's most likely adiposity that is most effective, the most important aspect in patients with asthma and obesity. Adipokines are cytokines secreted by the adipose tissue. It is not just a bystander to cytokines, the leptin and adiponectin. Leptos means thin. So when you are having adequate amount of fat or adipose tissue, there will be increasing amount of leptin that is secreted from our body, and leptin in turn reactivates or activates a cascade of inflammatory cytokines, interleukin 6, TNF alpha, interleukin 1b, and interferon gamma, and it will reduce the anti-inflammatory cytokines like interleukin 4 and interleukin 10, and there will be a significant amount of immune dysfunction, and there will be a systemic inflammation in these patients with adiposity than in a normal person who is having normal adipose tissue. And this is exemplified here as well. There the adipose tissue secretes TNF alpha, interleukin 6 and interleukin 1b, which in turn activates this innate lymphoid cell, and then you will have an untype 2 type of a reaction which causes airway hyperresponsiveness. So adiposity seems to be the driving force together with leptin and other cytokines in asthma. And this is beautifully shown in this graph, where in obesity there will be increased leptin, reduced adiponectin, and increased serum interleukin-6 and oxidative stress. And you can see that these graphs, especially the ones in the parentheses, show that when you have weight loss, you will reduce these markers significantly. And as a result, there will be increased hyperresponsiveness when you have increased biomarkers like this. But when you reduce the weight, you will have an improved response. And again, the severity of asthma and everything, and especially the susceptibility to air pollutions also will reduce if you lose weight. So asthma seems like a syndrome. It's an obesity asthma syndrome, which is a concurrent situation where there will be a genetic predisposition, there will be a metabolic and immune dysfunction, there will be mechanical effects in the lung, there will be alterations in the microbiome, especially the bacteroids, which are very important in short-chain fatty acid involvement, diet, as well as smoking and air pollution. So basically, lifestyle modification, rather than aiming to treat asthma, which is very important here, it is very important to promote the healthy lifestyle, look at the differential diagnosis, treat the comorbidities, and think about current therapies that are coming in the pipeline. So pregnancy is another category that I would like to talk about in this special AMA group, where obesity is basically adiposity, causing a systemic syndrome, causing poor asthma control in certain groups of people. Pregnancy, again, is a transient physiological state, has been associated with poor outcomes when it is there with asthma. When you look at the maternal outcomes, this is actually studying about 25,000 patients. We can see that preeclampsia, hypertension, placentia previa, abruption, premature rupture of membrane, gestational diabetes, and maternal hemorrhage, together with maternal intensive care unit admissions, are more prevalent in patients who are having asthma during their pregnancy. And when you look at the fetal outcomes, unfortunately, we can see that preterm deliveries, preeclampsia, low birth weight, small for gestational age, are again associated with poor asthma, in pregnancy, especially the perinatal mortality, and as well as congenital malformations are more common in people with asthma than the non-asthmatic. And more importantly, when we are looking at the subgroup analysis of these studies, what we see is that, especially if you have controlled asthma during pregnancy, except possibly preeclampsia, most of these odds ratios becomes non-significant, and especially when you're dealing with congenital malformation, that is the case. If you have well-controlled asthma, then the risk of developing adverse fetal outcomes are very less, and that is very important. That's a very important point that we have to stress. And in the same time, we know that especially in patients with asthma pregnant, when they become pregnant, up to 45% of the women will have severe exacerbations, and the rate of hospitalizations are more, and they have 3 times more rates than a normal non-asthmatic patients. Even though the changes in asthma severity, we say 1/3 will become better, 1/3 will be staying safe, and 1/3 will actually get worse. So even though we have adverse fetal and maternal outcomes with asthma, at the same time, their clinical severity also is significantly more than in non-pregnant patients. And one of the major reasons for that is that they are more likely to be undertreated, depending on according to the level that is needed treatment. They are not treated by the physicians because the apprehension of side effects of drug, and as well as not diagnosing asthma properly. And at the same time, when we look at the pregnant asthma patients, they usually avoid medication, especially between the 5th week of gestation as well as 13 weeks of gestation, simply because probably as soon as they know that they have become pregnant, they stop taking asthma treatment, even though they were properly controlled. And it is very important to note that the avoidance of asthma exacerbation in the first trimester is very important, because that is the area where you can have increasing amount of congenital malformations if the asthma is not properly controlled. And these messages should go to the patients as well as the physicians, emphasizing the need to control asthma properly. And with the physiologic and the physical changes in pregnancy, we know that relaxin and certain hormones will reduce increase the compliance of the thoracic cavity. Hence, the angle will be increased, even though there will be a 4 centimeter diaphragm because of the gravid uterus, especially after the later stage of pregnancy, but it will not cause a significant reduction of the total lung capacity because there will be increasing of the diameter of the thoracic wall, especially in pregnancy. So the tidal volume will only reduce total lung capacity, not the tidal volume, sorry, the total lung capacity will reduce only about 5%. But because of the progesterone effect, there will be increasing amount of breathing. That means tidal volume will increase as well as the depth, hence the minute volume will increase, where you create a metabolic alkalosis, but it will be compensated by the kidney, where you can have normal carbon dioxide and pH levels with low bicarbonate level in a pregnant lady. And in here, the important aspect is that the forced vital capacity as well as FeV1 to FVC ratio and the closing capacity are not changed in pregnancy whatsoever. And these patients also breathe at the lower range of the expiratory reserve volume, where the airway narrowing is more, and hence opening up the airway will need more mechanical power, and hence the asthmatic patients, pregnant patients, will have difficulty or will need more support than a non-asthmatic patients when they have a severe attack with bronchospasm. Now, an interesting diagram here, which I would like to discuss, where in a normal non-asthmatic patient, you have, because we are dealing with a parasite, a fetus inside, which has about 50% of paternal antigens in him or her. And because of that, to keep this fetus, we have reduction of T cell Th1 immunity, increasing of Th2 immunity, and increasing of Treg, which is usually because of the effect of the hormonal effect, where the estradiol is one of the major hormones. But when you have well-controlled asthma, so in pregnancy, there will be more towards a Th2 response than a Th1 response. But in well-controlled asthma, this Th2 response, even though it is higher, it is very well regulated. And the Treg, the regulatory T cells will suppress the natural killer cells and the Th17 cells, keeping in check of the unwanted immune response towards the fetus. But as a result of the Treg protein, there will be reduced cell-mediated immunity, and that might predispose a pregnant lady for viral infections as such. But if the asthma is not controlled, there will be an exaggerated Th2 type of a response, and the T regulatory cells will reduce in number, causing an increasing natural killer cell and Th17 activity and cytokine activity. That might explain the abnormal placental and the fetal as well as eclamptic outcomes in patients who are having poor asthma control, especially in pregnancy. Now, the hormonal effects are very important. That might explain some of the outcomes of asthma, why it is severe. We know that increased free cortisol is anti-inflammatory, and it increases the beta-adrenal receptors, which is positive in asthma. And prostaglandin also helps inhibition of smooth muscle proliferation. But progesterone has two effects. It dilates smooth muscles, facilitating airway bronchodilation. At the same time, dilates the lower esophageal sphincter, increasing the reflux, and it downregulates the beta-adrenal receptor, especially in the lymphocytic cells, causing increased bronchoconstriction. So it has two actions, and depending on the balance, it might go one way or the other. And estrogen, we know that even though it enhances T cell regulation, it increases bronchial mucus production as well as AR cell edema as well. And interestingly, fetal sex, especially of having a female sex, has shown to be more detrimental to the maternal asthma control than male sex. Even though there have been various theories, it is not very well established. Again, gestational rhinitis, which is a very common factor, should be controlled in asthma, which is the estrogen effect, and esophageal reflux, overweight and obesity, depression, obstructive sleep apnea, and anxiety always might come hand in hand with asthma, as well as it might be a presenting complaint for a dysfunctional breathing. And especially in Sri Lankan context, we have to be very careful not to miss cardiac pathologies like peripartum cardiomyopathy, valvular heart disease, which might be undiagnosed even after the third or fourth pregnancy. Hence, it's very important to look at these aspects as well. About the drugs, in summary, I would like to say that corticosteroids, especially the inhaled corticosteroids, have proven to be of any harm, especially the budesonide with the normal therapeutic doses. But the beta agonist has some significant problems when we are dealing with patients with asthma. And oral corticosteroids, especially, we should be avoiding unless it is truly needed, and according to the British guideline. But finally, what they say is, if it is well controlled throughout the pregnancy, and it's very important to control the adverse maternal or fetal complications, and always the risk of harm to the fetus from severe or chronically undertreated asthma outweighs the small risk from medication. Hence, they suggest to use any of these medications according to the requirement and according to the step. So basically, it's better to use something like budesonide rather than combining with a LABA, and go into the second step of having high dose inhaled corticosteroid rather than combining with a LABA, rather than and reducing the amount of short-acting bronchodilators as much as possible would be the best way forward. And acute asthma management is not different from non-pregnant patients. The important thing is to keep the saturation, maintain the saturation at around 94 to 98, and continue the fetal monitoring. And there are no differences between drug therapy. And during labor, also prostaglandin should be avoided. And if there is anesthesia is required, regional blockade is advised. So in summary, basically in asthma in pregnancy, it is very important to understand that the treatment options are there. The unfortunate thing is that, but unfortunately, the controlling of asthma will depend on the maternal as well as the physician input. Hence, convincing the patients of the importance of taking treatment is the cornerstone of management to prevent unnecessary outcomes. Now, this lady, Amy Van Dyken, is a very important person who has won almost 6 Olympic gold medals during the 1996 and 2000 Olympics. One thing that she had was asthma. So she was diagnosed with asthma at the age of 18 months, and hence was sent for swimming by the doctor, and finally she became an Olympic champion. And that is one important thing that we have to tell children and adolescents who comes to us with asthma, and we should never ask them to stop doing the normal exercises even though they have asthma. And hence my third and final topic would be on exercise and asthma. Now, even though they have a long history, even from the early stages, asthma patients, they have known that after exercise, patients become more dyspneic. And in the 1960s, they have noticed that asthmatic patients after exercise, after about 5 to 8 minutes of exercise, become more dyspneic. Hence, the name exercise-induced asthma came to the picture. But later, it might signify that asthma is induced by exercise, hence it was changed. And they have noticed that there are a certain group of people without asthma having bronchoconstriction objectively. Hence, because of that, this broad group where patients, this graph is beautifully, it's there. After exercise, after about 5 to 8 minutes, especially during the hyperventilating phase, you will have a significant drop in the post-expiratory volume. Increasing of airway caliber is there. Then later it will slowly increase up to about 1 year, where you will have a refractory period where you will not have bronchospastic exertion, and then you will have a flat-free for about 3 hours. And that is basically exercise-induced bronchoconstriction, which is around 90% of the cases, they will have underlying asthma, but there are about 10% where you will not have asthma, but you will have exercise-induced bronchoconstriction only, especially in the elite or Olympic athletes. They have a prevalence about 30 to 70% of exercise-induced bronchoconstriction. And this is Greg Louganis, again, an asthmatic who has, swept the diving events in consecutive Olympic Games. And that means that if we identify these patients and appropriately manage these patients, they can aim for higher things. And other group of people who are more prevalent to have exercise-induced bronchospasm or bronchoconstriction is children, where the prevalence changes. When you have EIB alone, the prevalence is about 10 to 20, but when it is combined with asthma, it is about 50% EIB is there, range depending on the population that are studied. So what basically happens to understand the pathophysiology, usually when you breathe air in a normal person, you breathe about 10 to 12 liters of air, which is humidified to that, and it is 100% that humidified, and you have a 37-degree temperature when it reaches the lower airways. And but as you try to hyperventilate, what happens is in a college athlete, it will be reaching about 25 liters per minute, where you start to breathe not from the nose, but from the mouth. And in an elite athlete, you can breathe about 200 liters per minute. And you can see that the respiratory water loss increases gradually, trying to humidify this rapidly ventilating air, and you will lose heat as well. And at the same time, you will drop the FEV1 level. So when the respiratory water loss is proportional to the FEV1, and that is the pathophysiological mechanism that is explained in patients who are having exercise-induced bronchoconstriction. And this is exemplified, it's beautifully explained here, where when you have dehydration, there will be osmotic changes in the epithelium, which will activate phospholipases and various other enzymes and cause degranulation of the eosinophils as well as the mast cells, which in turn will secrete cystinyl leukotrienes as well as histamines and tryptase, which will stimulate the nerve cells. And these nerve cells, sensory nerves, can stimulate the airway smooth muscle. At the same time, they can secrete neurokinin, which will increase the blood cell secretion, increasing the secretions as well as the caliber of the airway, causing exercise-induced bronchospasm. And this beautifully illustrated by by Holstrand, where histamine and tryptases are formed, and you can see beautifully that from the post exercises, your drop with the FEV1 is markedly there after about 8 minutes, and then it gradually catches up. And at the same time, you will have increasing amount of histamine and increasing amount of histamine and tryptase in the locality. Now, there are two basic theories: the thermal mechanism, which is now not, it is distributed now, but the water loss and the hyposmolar environment, shell sinkage, and the mediator release is the one of the mechanism that is then identified. But here also there are some subphenotypes that have been recently coming into the picture. Especially they have done a beautiful study in Italy, where they have followed up Olympic athletes for about 8 to 12 years, where earlier T2 signals and the later T2 signals were measured clinically, and they have identified that the athletes who are, undergoing exertion or training has increasing amount of T2 high responses, proportional to the duration of the time that they have undergone exercise. And at the same time, we know that again that recurrent viral infections as well as the epithelial injuries, especially these athletes train in high polluted areas, sometimes with increasing amount of particulate matter, and these changes are different from the T2 responses, and the treatment options might be different. And the small airway, especially because patients are breathing in a lot of air inside and out, especially there have been noticed that club cells secreted certain, it's an indicator of damage, of small airway damage. And in certain athletes, they have identified that small air damage is there in patients. And autonomic dysregulation is another factor that they have identified, and that might explain that certain athletes with exercise-induced bronchoconstriction respond more to antimuscarinic ipratropium rather than beta stimulants. So even though in exercise-induced bronchoconstriction, even though the pathophysiological mechanism are identified, there seems to be subphenotypes that might be important in treating these patients. Right. And it has a genetic component as well. And as this study in PLOS ONE beautifully exemplifies that, especially in patients who are having EIB positive, actually it's exercise-induced bronchoconstriction positive patients have increased transcription of these genes that are identified. So there will be a genetic predisposition like the environmental factors that are there. So basically, how will you diagnose exercise-induced bronchoconstriction? The methacholine test, the Eucapnic, the Eucapnic voluntary hyperapnea, the hypertonic saline, and the mannitol inhalation, and the exercise challenge are called the indirect measures of checking the air bronchoconstriction, where you create a condition where the airways are dehydrated, similar to when you're hyperventilating. And the methacholine is a direct mechanism where you check the bronchoconstriction. And these are accepted by the International Olympic Committee. And this is what we call the Eucapnic voluntary hyperventilation testing, where a person is subjected to inhale 5% carbon dioxide and 75% nitrogen and oxygen. Breathes at around 30 times the forced expiratory volume for about 6 minutes, and within 30 minutes you check the FEV1, and if there is a 10% drop, that is basically it's a positive test, and this is basically an indirect test of measuring the exercise-induced bronchospasm. I'm sorry about this slide, but it gives a very good summary of how we come into a person with, how will you diagnose a person with exercise-induced bronchoconstriction, where you ideally do a spirometry and then if the FEV1 is more than 70%, you can do a reversibility study, and if the reversibility is there, then it is consistent with asthma and high risk of exercise-induced bronchospasm, and you treat as a EIB with asthma. And if it is more than 70%, but there is no reversibility, then we have to go for a indirect bronchial provocation test, like the Eucapnic hypovolemic response. And where if it is positive, then it is ideal. It is just simply and the treatment of choice is you can use a beta agonist before 15 minutes before exercise, and if it is, but important thing is it should be less than 4 times per week, or else there will be tachyphylaxis. You can use leukotrienes 2 hours before the exercise, and then you can use mast cell stabilizers. But if there is no negative hyperresponsiveness, then we have to think about other differential diagnosis that can mimic exercise-induced bronchospasm. And one of the more important thing is that the vocal cord dysfunction, especially common in female athletes, which is associated with stridor rather than wheezing. And they will have, if you do a flow volume loop, there will be flattening of airways of the flow volume loops in these patients. And other one, the important thing, especially in elite athletes, you can have exercise-induced arterial hypoxemia and swimming-induced pulmonary edema, especially in swimmers. And there will be the exertion-induced hyperventilation, or the most common one would be the poor physical fitness, where these patients will have a high heart rate after low-grade exercise. So differentiating the laryngeal, the exercise-induced vocal cord dysfunction is very important in these patients, because they will complain of a throat pain rather than a chest tightness, and there will be inspiratory stridor, and as soon as the exercise stops, they come back to normal. So this is the final 2-3 slides, and where the algorithm is a very important algorithm that we can use to identify patients with exercise-induced bronchoconstriction, where you have symptoms of dyspnea, wheeze, cough, and chest tightness. And if the baseline FEV1 is more than 80% predicted, if it is not more than 80% predicted, you can think about this most likely has a bronchodilator response. And if there's a bronchodilator response, that is most likely it is asthma. But if the baseline is more than 80, we can use the indirect test, the dry air exercise challenge, the Eucapnic voluntary hyperapnea and mannitol challenge. And if it is positive, then this patient only has EIB. And then you can think about managing as beta agonist as needed. And if there is no clinical improvement, you can think about adding corticosteroids or until sufficient clinical improvement is there. But if it is not improved, we have to think about the secondary causes of EIB. So basically, the important thing is to identify whether this patient has having underlying asthma and treat it appropriately. In about 90% of the patient, this might be the most important thing in treating AIB. Right. This basically, this graph shows that the high intensity pathophysiology and how you can, what are the measures that you can take other than the pharmacological treatment. So when you have high intensity aerobic exercise, there will be increasing amount of ventilation, and this will be assessed with the high intensity exercise test and the Eucapnic voluntary hypopnea. And this dry air will be the trigger factor, which may cause transient airway dehydration, which can be prevented by cold weather mask or scarf and nasal breathing, and treating allergic rhinitis, because these patients have significant amount of allergic rhinitis. And then this transient airway dehydration can be mimicked by mannitol, but airborne pollutant or allergen in the environment. So one thing is to improve the, reduce the cold weather entering the lung, and the other one is to reduce the airborne pollutant and the allergen environment. And at the inflammatory mediator release step, inhaled corticosteroids, montelukast, and chromoglycolic acid has a place in controlling EIB. And then when you have constriction, bronchoconstriction, you can have short-acting bronchodilators. And then the refractory period is very important. Hence, that is an important thing in asthma or as well as EIB, exercise-induced bronchoconstriction, where you have to have adequate amount of warming up as well as warming down periods for these patients, so that they will have less tendency to develop bronchospasm during exercise. Hence, when you look at the complete management plan, the pharmacology management are at the bottom, where you can use these aspects, and at the same time, reducing the airborne pollutant and allergen environment and avoiding cold weather is also a very important aspect. But when we are treating, we have to think about the important thing about the physician guidelines, especially in asthma, the World Anti-Doping Agency guidelines, and this is one such guideline about salbutamol, and we have to know about which drug to give and which drug to not give, and how much we can give. So these are available freely in the Anti-Doping Agency. So I would like to end my presentation by highlighting about Jackie Joyner-Kersee, who was again diagnosed with asthma, and she has more track and field medals than any other American woman in history. And these three aspects of asthma: obesity, which is probably adiposity syndrome, which needs lifestyle modification as well as asthma treatment; pregnancy, where the most important aspect is to educate the patients as well as the physicians about the importance of treatment options, as well as the negative ability of causing side effects of the drugs. And in exercise-induced bronchoconstriction, the most important part is to identify these patients early and appropriate treatment initiated, prevent unnecessary psychological abnormalities, psychological stresses in these patients, as well as and help them to achieve the maximum possible outcomes of their physical activities. Thank you very much.
Thank you, Niranjan, for that comprehensive lecture. Due to the constraints of time, we will take only a few questions. There are many. Chandimani, would you like to take the first question?
So the first question is actually to Dr. Ian. Can you hear me?
Yes, I can. Yeah.
Yes, hello. So there's a question on fungal sensitized asthma. So the question is, would you consider fungal sensitized asthma as a separate phenotype? And if so, what would you consider as clinical characteristics, and whether there are any biomarkers that would help us to identify this?
Well, yes, I suppose it would. And we all recognize this group of patients that usually have very florid type 2 airway inflammation that produce very thick mucus plugs, particularly likely to obstruct airways. And there's quite good evidence of airway damage. What I think we don't know is whether the airway damage comes first or whether it's caused by the mucus plugging. I think we often assume the latter, but I'm not sure that's been firmly established. And we also don't know to what extent the aspergillus itself is contributing to the problem, or is it just the hypersensitivity, the IgE-mediated response to it that's the problem. So the data on antifungal treatment in aspergillus-associated asthma, I prefer that term to ABPA, is not very convincing. And it's a little difficult to interpret because antifungals are, or at least itraconazole is an enzyme inhibitor, and it will increase blood prednisolone levels and endogenous steroid levels. So it might help by a non-antifungal mechanism. So I certainly recognize it as a phenotype. We see a lot of aspergillus sensitization in the UK in severe asthma populations. They tend to be floridly type 2 high. They do very well with biologics. A bit like the aspirin sensitivity subgroup, which I know somebody asked about. They also do incredibly well with biologics. So yeah, I do recognize it. I'm not sure fungal sensitization is a treatable trait in its own right. I'm interested in what other people think.
Let's go to the second question. One of our viewers would like to know from Dr. Manil Peris, what's the reason for a lower recommended daily dose of formoterol when combined with beclomethasone than when it's combined with budesonide?
Yes, actually, I also don't know the answer to that, and it was in my mind as well when I saw this. In the GINA guidelines, it's mentioned as that it is the product information, what they have got from the product information, and that's why they are going with those values. I wonder whether Professor Ian or Dr. Ronald has any information on why the discrepancy between budesonide formoterol maximum dose and beclomethasone formoterol maximum dose in the GINA guidelines.
Well, I'm wondering if it's got something to do with this small particle in the CFC-free, the HTA metered dose inhalers, because as you know, we assume that the steroid dose is twice as bioavailable. So you know the beclomethasone dose is dosed at half what it would be with a CFC. So maybe it's the same thinking in relation to formoterol, but I'm guessing.
Okay.
There's a question for Dr. Liu. Is he there online with us?
Yes.
Yes, Dr. Liu, one of our viewers want to know what is the role of bronchial thermoplasty in difficult asthma, and how would you sort of assess them for this?
Well, I'm no expert in bronchial thermoplasty, but certainly I know there are some subtypes. They have very heightened airway constriction function, and then thermoplasty has been shown to work very well. Perhaps Professor Pawad can tell us whether this is one of those treatable traits that you would be able to identify when you endotype those patients.
Yeah, I mean, I have done thermoplasty. I don't do it now. The population that went into the clinical trials all had huge bronchodilator responsive airflow limitation and very twitchy airways. So Ronald, I absolutely agree with you that that's probably the trait we're treating. The difficulty I have with thermoplasty data is it's not that convincing or consistent. No. And it's been hard to link efficacy to a measured characteristic. And I think what we need in asthma is to know what we're treating, what's the trait we're treating, and what is the clinical consequence of treating that. And I'm not sure we've nailed that with thermoplasty. And that might be one reason why it's not done widely, I think.
Yeah. And it's a very mundane procedure that takes hours to complete, and you have to be very meticulous going through airways by airways. And And I think it's as good as in a clinical trial setting, but in actual private practice, like what I mean, is that it's not one of those things that we will engage ourselves in very easily.
Thank you. One last question. Niranjan, one of our viewers would like to know if there is any association between asthma exacerbations and preterm delivery in pregnant asthmatics. Is there any evidence for that?
Yeah, Gutal has highlighted asthma is associated with a significant amount of poor fetal outcomes, and preterm delivery, small for gestational age, as well as the placental complications are known to be associated, especially with poorly controlled asthma, which is not under control. But sometimes when the asthma is controlled, well controlled, these differences, even though they are still there, the significance is reduced.
Thank you, Niranjan. Now, we have a lot of questions, but due to the time constraints, we will wind up now. The proceedings of the recordings of this this webinar will be available in the website as well as in the Facebook of the Sri Lanka College of Pulmonologists. On behalf of the president of the Kandy Society of Medicine, Dr. Dushanta Madagedara, and the president of the College of Pulmonologists, Dr. Nandika Haresh Chandra, I would like to thank all the viewers and all the speakers who made it a reality to have this webinar, which was very informative. Thank you very much and good night.
Good night.